Good morning, this is Dr. Ahdoot, and as many of you may have heard, Al Roker was recently diagnosed with prostate cancer. And I know this sounds scary, but I really got to commend him for bringing this out, making it public, and using his voice to educate people about prostate cancer. In line with that, I want to discuss what we know about his diagnosis, help you understand it a little bit better, and at the end, extrapolate from that so you can essentially get the quality of care that he's getting. So without hesitation, let's jump into it. So Al Roker was first diagnosed with prostate cancer because of a blood test called PSA. It's a very simple blood test. Whenever your doctor collects your blood, they can just add it on. It's cheap, it's very easy. It really isn't anything more for you aside from the traditional blood work you do. And what that blood test does is it measures a protein that circulates in your blood that's produced by the prostate. And everybody has some level of PSA, but when you develop a prostate cancer, your PSA level, or your PSA gets overproduced. And that leads to a rise in the circulating PSA level. So generally, we usually go by a cutoff of around 4. You say you have a PSA of 4, then you have high risk of prostate cancer, with around 40 to 50% of people who undergo a biopsy at a PSA of 4 having cancer. But it's kind of a gradient. You can have a PSA of 3 and still be found to have dangerous cancer, and that happens around 30% of the time to 40% of the time. So as you can see, PSA is not a perfect test, but it gives you an idea of where your risk is. And that's where Al was diagnosed initially with prostate cancer. So he had this elevated PSA and his doctor thought, oh, this is a little concerning. Why don't we evaluate it a little more? And it's very important here, they didn't jump straight to a biopsy. Before they did a biopsy, they did an MRI of his prostate. And that's very important because actually we can't see prostate cancer with CT scans usually, with ultrasound usually. The only imaging technique that we can use to actually see prostate cancer is typically MRI. So the fact they got an MRI allowed them to then target their biopsy towards a specific spot in the prostate. I talked about this in a previous video about MRI targeted prostate biopsy and whether your biopsies can be wrong. And it turns out if you don't know where you're targeting within the prostate, you just kind of do random samples of the prostate, there's a good chance you'll miss the prostate cancer. But once you have an MRI, which shows you the area of cancer, and then you target the biopsy to that area of cancer, you have a better chance of detecting it. So that's what happened in Al's case. He got an MRI and the physicians at MSK essentially did an MRI targeted biopsy and found an area of cancer. Now they described his cancer as somewhat high risk. And when you look at prostate cancer, it usually comes into 5 categories. The lowest grade or grade group 1, and then the highest grade or grade group 5. This correlates with Gleason 6 and Gleason 10, but we're gonna stick with grade groups. So these grade groups essentially go from least aggressive to most aggressive. And actually grade group 1 cancer, you almost always do not need to treat it. You can just watch it and just make sure it doesn't change into something worse. And about all those patients do just fine. So it's very important that we don't over-treat prostate cancer. And that's kind of what happened a lot in the 70s, 80s, 90s, was just a ton of over-treatment of prostate cancer where everybody with Gleason 6 or grade group 1 prostate cancer was treated and they did not need to be. Now we are more knowledgeable, we've done studies, and we know that that kind of low-grade cancer, or the grade group 1, also known as Gleason 6, just doesn't kill people. But that's not what Al has. Al has what they described as somewhat more dangerous cancer. And I think, based on their description, that he probably has somewhere in the middle. Not the most aggressive grade group 5, but probably something like grade group 3, which is a kind of cancer that actually the majority of the time doesn't spread, but has still a pretty substantial risk of spreading, and then potentially, if it spreads, it's no longer curable. So the goal with prostate cancer is find it early, treat it early, and then don't have to worry about it. Once they finally made that diagnosis, they discussed with him the treatment options. And you might be thinking, well, why did they choose surgery? Why did they choose radiation? And I have a whole video just on that topic. But generally, they're quite similar. And the main distinguishing factors about whether to choose surgery and radiation are actually questions about the side effects you're willing to accept and your age and how long you're expected to live after treatment. And if you want to know more about that, please jump into the video about surgery versus radiation in terms of their complications. And I go into all the literature on it. So now that we kind of know where he's at and we know that he's planning on surgery, the real question most people want to know is, how is he going to do? Is he going to be okay? And I'm going to pull up a graph right now to show you the outcomes of people who undergo surgery. And what you see is that when people undergo surgery, their actual risk of dying from prostate cancer is extremely low over the course of 10 years. Like under 1% rate of death from prostate cancer over the course of 10 years. The reality is that surgery or radiation, when prostate cancer is caught early, can be nearly 100% effective at curing prostate cancer if it's treated effectively. With surgery, if you get the entire prostate out there and you have negative margins, there's almost no chance that prostate cancer will come back. With Al's likely intermediate cancer, I think he's probably around grade group 3. His risk of prostate cancer leading to progression or spreading to other parts of his body is actually slightly higher than I quoted in that table. So that table I showed you shows you the risk of all patients who undergo surgery for prostate cancer, but many of those people were the grade group 1 or the low risk people. I would suspect, based on what they've said, that Al's probably in grade group 3, which would make his risk of cancer spreading a little bit higher than what I quoted, but still it's higher than a very small percentage. So when we look at the outcomes for men with grade group 3 cancer, we find that anyone with grade group 3 or higher cancer has an 8-fold higher risk of metastasis relative to that graph I showed you, whereas people with grade group 2 have only a 3-fold risk of metastasis that's higher. Now you got to remember, this risk of metastasis is only a few percentage points. So if that risk goes up around 3 to 4-fold, which is probably what's appropriate or descriptive of Al's case, that's still a very, very low chance. So overwhelming odds are in his favor that he's going to be cured of his cancer. So I go over this because I want you guys to respect what Al's trying to do here. He's trying to share his experience so other people learn about screening and that they can take care of themselves. So what you need to know and what you can learn from all this is that prostate cancer screening is very, very effective at detecting prostate cancer way, way, way before you'll ever have symptoms. If you've started to develop symptoms from your prostate cancer, it's very likely that it's too late to cure that prostate cancer. Nowadays, with most cancers, the name of the game is finding the cancer before you have symptoms. Waiting for symptoms for cancer is essentially going to make it too late for you to cure the majority of cancers. So screening is about looking for cancer when you have no symptoms. And that's exactly what a PSA does. It's a cheap, easy test that can be done by even your primary care doctor, just to look at your PSA level. If your PSA level is high, then you just go speak with a specialist and they'll tell you whether or not you need to do anything more. That's about it. And like I said, if your PSA is high, spring for the MRI before you go for a biopsy. I think that's a very good piece of advice and I can universally support it. Second thing that comes up is, all right, I'm considering getting my PSA checked, but at what age do I do it? Now, I will say the AUA guidelines or the American Urologic Association guidelines say to start at age 55 and test all the way through the age of 70. I think these guidelines actually are not the best. I would actually prefer testing earlier. So I'll just say that for general people without any risk factors or any family history that are not African American, usually I would probably recommend people start testing in their late 40s or at 50 years old. If, however, you're African American or you have a family history of prostate cancer or you have a known genetic disorder that causes you to have a higher risk of prostate cancer, you should probably screen 5 to 10 years earlier. So I would consider, men with these risk factors to start screening around 45 or 40 years old even, with just a simple blood test every year. And then the last thing, and probably the most controversial, is a digital rectal exam. And this is that exam where a doctor essentially puts their finger inside your rectum and they feel your prostate to try and feel any lumps or bumps. And I think men often dread this. It's embarrassing, it's a little uncomfortable. I mean, your doctor doesn't care, they do it all the time. It means it's just us trying to take care of you. But I understand that people have apprehensions about it. And I usually don't push people. If it's gonna be something that scares you from going to the doctor, it's okay to skip it. When you look at the statistics or the results of studies, we find that only 3% of prostate cancers are detected in men by a digital rectal exam, right? And even if you decided not to get a digital rectal exam and you were one of that 3%, checking your PSA over time, we probably would catch it as your prostate cancer grew the next year or the next year. So if you just do an annual PSA and you are not comfortable doing a digital rectal exam, you'll still get huge benefits. Although if you want it to be as complete as possible, a digital rectal exam does add to some cancer detection. So in all of this, I think I want to just say, I'm very inspired by Al and his courageousness to share his diagnosis with people and to get the information out there so that people become more informed about prostate cancer. Ultimately, my goal is to stop seeing so many people die of cancer. And it's undeniable. It's the second leading cause of death in the United States. It's often preventable and curable if identified early. So the goal here is get your screening, have an intelligent person interpret it, an appropriately trained urologist, and you should be pretty safe. So if you found this information interesting and you want to know the most cutting-edge information about various cancer treatments, not just prostate cancer, over the course of the next year, we're going to be discussing many cancers, what you can be doing to get the best treatment possible, and eventually what you can do to prevent these cancers. If you have any questions about prostate cancer and about Al's situation in general, please leave a comment. I'm happy to answer them. Thanks. This is Dr. Ahdoot. I'll see you next time. The topics discussed in this video are for educational purposes only and should not be used to make medical decisions. Every individual has unique circumstances which will influence their medical care, and application of scientific literature should be interpreted within the context of your general health. Please consult a doctor before making any clinical decisions.